All right, everybody, welcome back to our part two of our foundations video for module one here in the abnormal behavior class. I want to highlight just a couple of things for you here in the second video. And really what we want to talk about is the DSM-5, this textbook, this purple textbook that I shared with you earlier in our first video during our welcome, that this textbook that we use in this class, the DSM, is really unlike any other textbook that we use in any of our other classes. And if you have already purchased the book and reviewed it, which I really want you to do, you've already found it's not like a normal typical textbook. The DSM-5 is kind of central in many, many ways when it comes to assessing and evaluating mental health conditions in our culture and society. It is, as we talked about in the last video, that is the focus of this abnormal behavior class, is mental health conditions. Let me just say up front, I'm glad that we require you as a student to purchase the DSM-5. I think it is a great resource tool for you to have in your library. I think it is good for you to get exposed to and familiar with. Now, here's the thing I want to say to you. Does that mean that when you graduate from this class, you can use the DSM-5 to diagnose other people? The answer is no. The DSM-5 really technically is only used by psychologists, psychiatrists, and licensed master's level clinicians, like a master's level social worker or a licensed professional counselor. If you don't have a PhD, you're not a licensed psychologist, you don't have an MD, or you're a psychiatrist, you don't have a master's degree plus a clinical license, then you really will probably never use the DSM-5 officially to diagnose and evaluate someone, but that's okay, okay? That doesn't mean that it's not important for you and I to learn and to use in this class. I want you to be familiar with it. But again, I want to warn you, sometimes knowledge is a dangerous thing, right? And so one of the temptations in a class like this is you start using the DSM-5 as a part of this class, you start learning about all these mental health conditions. And I know the junior psychologist that lives inside all of us, right? We want to take that DSM-5 and take it home to our family or take it to our boyfriend or whoever and start evaluating, diagnosing people. Don't do that, okay? I just want to warn you, please don't do that, okay? So the DSM-5 is really primarily used by those types of professionals, but it's a great resource book for all of us to be familiar with. The DSM-5s, the DSM stands for Diagnostic and Statistical Manual. The 5 means that it is the 5th edition or the 5th revision of this book. About every 10 or 15 years, the American Psychiatric Association reproduces or revises and gives us a new DSM. When I was in graduate school many, many years ago, it's been many years, when I was a student in your chair, I was required to purchase the DSM-3. That's how long ago I was in school, the 3rd edition. I worked for many years as a clinician with the DSM-4, and now we have the DSM-5. And so it's good that the APA updates the DSM every 10 or 15 years to put in new information and new data, to put in new findings, because things are changing and evolving all the time. And so the DSM serves several purposes. And I want to review this with you as well too. Number one, the DSM's primary purpose is to provide what we call the diagnostic criteria for mental health conditions. In other words, it gives us the list. It gives us the symptom checklist. And it defines for us as professionals what is schizophrenia. And I'm going to use schizophrenia as an example. We're going to talk some more about schizophrenia starting in module number 2. But I'm just going to use schizophrenia as an example. Well, schizophrenia technically is not what I think it is or what you think it is. Schizophrenia technically is a mental health condition as defined in the DSM-5. That is, the DSM-5 is the standard that psychiatrists, doctors, counselors, therapists, students, it is the measuring stick that we use when we interview a client. If you're a licensed professional, you're a psychologist, and you interview a person and you think they may have bipolar disorder or schizophrenia, how do you know whether they have that disorder or not? Well, you interview them and gather information about their symptoms, and you lay it down next to the DSM-5. You lay the symptoms down. It is the measuring stick. It is the yardstick. If we did not have the DSM-5, it would just be based on opinion. Well, in my opinion, no offense, our opinion is important, but ultimately it doesn't count because we can have different opinions. So whether or not a person has post-traumatic stress disorder, if I'm doing an evaluation as a therapist and I'm trying to determine whether or not someone has post-traumatic stress disorder, for example, well, how do I determine that? Well, first I have to study what post-traumatic stress disorder is as defined by the DSM-5. Not Wikipedia, no offense to Wikipedia, not my mother, no offense to my mother, not my brother, no offense to my brother. What does the DSM-5 say post-traumatic stress disorder is? What are the symptoms? And if my client meets those symptoms, meets that criteria, then I can diagnose them with blank, fill in the blank, PTSD, schizophrenia, or whatever. So the DSM-5 is kind of a standard. It is the standard. It is the measuring stick. So that's why it's good for you and I to become familiar with it. So it lists many, many things for us, but that's the main thing that it lists. I want to highlight this little handout. One of the things I put for you in the module is this handout right here. I want you to make sure you look at it. Several semesters back, I made a list here of all of the things that the DSM-5 contains for us, all of the information that it provides to us for every single disorder. There are almost 300 different disorders listed in the DSM-5. Some of them maybe you've heard of, some of them you haven't heard of, right? And we're going to hit the main ones in this class as we've already talked about. With every single disorder, the DSM and those who research and put it together give us so much information. They give us the diagnostic features. I'm just going to review real quickly. They give us the prevalence. How common is this disorder? That information is in the DSM for every single disorder. They give us what's called the development and the course. Let me talk about development and course for a second. So every single disorder usually has a typical way that it begins to show itself in someone's life. So based on research, what is that way? So with schizophrenia, what do we know about schizophrenia? Is schizophrenia a disorder that sort of shows up out of the blue? Does it begin in childhood, adulthood, older adulthood? What is the typical development and course? And every disorder has a slightly different development and course. So the DSM gives us that information, general information based on years and years of research. It gives us risk factors and diagnostic as far as and prognostic factors, which just basically means how responsive is this disorder usually to treatment? Do people with schizophrenia, for example, respond well to treatment or not? What are some culture-related diagnostic issues we want to make sure we take into account? What are some gender-related diagnostic issues? Is this disorder more common in men versus women? And if so, why? What is that? Suicide risk. Based on our research, do people, I'm going to use schizophrenia as an example. Based on our research, not in my opinion, not in my experience, but based on our research across our nation, at what risk are people generally with schizophrenia? At what risk are they to try to hurt themselves or end their lives? Suicide risk. And every disorder is slightly different, right? Functional consequences is one of the things that DSM lists for us. So based on our experience and our research, people with post-traumatic stress disorder, I'll use that one as an example. Based on our experience and on our research, what other kinds of problems do people with PTSD often struggle with? What we call functional consequences. In addition to struggling with the symptoms of PTSD, for example, what other kinds of problems do people with post-traumatic stress disorder often struggle with in addition to that? Well, we know that based on research, and we can learn about that. What's called differential diagnosis and comorbidity. Let me mention those two. Differential diagnosis is a term that just means this. The DSM has done a lot of work for us. One of the tricky things, if you and I were in a classroom right now, I would draw a bunch of circles on the board, a bunch of overlapping circles, okay? And I always do that whenever I teach this class. I give those overlapping circles as a visual to highlight this. Many different disorders share symptoms. Many different separate disorders may have common symptoms. And so what that means is that different disorders can kind of look alike, and we want to be careful that we're able to separate out different disorders. The greatest example I use is the issue of sleep disturbance. So people with mental health conditions, often their sleep is disturbed. They sleep all the time, they don't sleep enough. They have a hard time staying asleep. So sleep is a common symptom of a mental health condition, sleep disturbance. Well, which mental health condition is it a symptom of? Well, many actually. People can struggle with sleep because of schizophrenia. People can struggle with sleep because of a sleep disorder like narcolepsy or sleep apnea. People can struggle with sleep because of anxiety. People struggle with sleep with depression. People struggle with sleep when they have bipolar disorder. So disturbed sleep is a common symptom of lots of different problems. So you gotta learn how to peel them out a little bit, and that's what differential diagnosis means. So the DSM, with all of the different disorders, gives us some information about what does this disorder often look like? What are other disorders that this disorder can look like? And then the last one it lists for us is comorbidity. The term comorbid means co-occurring, runs alongside. So certain mental health conditions, it's not uncommon for people with certain conditions. I'm going to use post-traumatic stress disorder as an example. So people with post-traumatic stress disorder oftentimes abuse substances. And those two things are separate, but they run together a lot. Does that make sense? People with depression, many people with depression abuse substances. Now, substance abuse and depression are two separate things, but they run together a lot. That's the term comorbid, right? Um, and so that's good to know. So when you study post-traumatic stress disorder, I'll go back to PTSD. When you study post-traumatic stress disorder and you read in the DSM, the little section under PTSD, the comorbid section, you'll see that the editors of the DSM give us lots of good information about what are some other common co-occurring types of disorders that often run alongside post-traumatic stress disorder and schizophrenia and bipolar disorder, right? All of that, all of that to say this: the DSM-5 doesn't just give us the symptom checklists. It gives us lots of good information based on research. That's a good thing. Even now, whenever the DSM-6 comes out here, who knows when the DSM-6 will come out? But even now, researchers and therapists and psychologists and medical schools are researching, and they're studying people who struggle with mental health conditions, and they're gathering information and gathering data. And all of that will go into the next DSM for us to be familiar with as professionals so that we can better help our clients and better educate ourselves. So the DSM-5 is a great resource book. It is kind of going to be our guide for this semester as we work with and as we talk about mental health conditions. One of the things with the DSM-5 is the DSM-5 is built upon what is called the medical model. And the medical model is also something I want to highlight here really quickly in this second video. The medical model is something that all of us are familiar with. And it is the model by which the DSM-5 is created. Probably 5 or 6 years ago in the springtime, I was teaching at Lone Star, and one day I just noticed that I just wasn't feeling well. And that's unusual for me. I'm in pretty good health, and most days I feel fine. But I just kind of noticed that I just didn't feel right. My body kind of didn't feel good. I was real tired, and it was just real unusual for me. And I went home early. And when I got home, I sat down in a chair in front of my television. I fell asleep. I slept for like 2 hours, which is very unusual for me. And when I woke up, my throat was really scratchy and my head was pounding. And I didn't have any appetite, which is unusual for me. Didn't eat any dinner. Went to bed, slept, got up the next morning, and I could tell something was wrong. I did not know what it was, but I was sick. I could just tell I was sick. I went to class. I taught my classes. And by the time I got done with my classes, I had total laryngitis. I had total voice loss. And I could not breathe. My head was all congested, and I was just sick. So I called my doctor, and my doctor was able to see me that afternoon. He said, "Come in at 4:30 and I can see you." So I went in that afternoon and sat out in the waiting area. I went back in when they called me back. The nurse came in first. And maybe you've been through, all of us have been through this. Here's what the nurse said: "What brings you in today?" Well, I didn't know what was wrong with me. So I just started telling her, "Well, I don't feel good." And she said, "Well, give me some examples." So I started listing all of my problems: voice loss, don't feel good, no appetite. I started listing all these problems. She was making some notes, right, in the chart, right? Then she asked me some questions. Do you have any fever? Have you been throwing up? Have you been coughing anything up? If you have, what does it look like when you cough it up? Is it like clear or is it something else? She asked me some questions, yes or no kinds of questions. She's gathering all this information. She writes it in my chart. She says, "The doctor will be in just a second to see you." 5 minutes, here comes my doctor. He takes my chart that the nurse has made notes in, and he just confirms what she has said. He asks me, confirms questions, He listened to my heart. He looked in my mouth. He looked in my ears, my eyes, felt around on my neck and my glands. And then he said this, I think what you've got, have you been there before with the doctor where the doctor says, well, I think you've got, he said, I think you've got an upper respiratory infection. And what we're going to do is I'm going to give you a shot and I'm going to write you a prescription for some medicine. And I want you to stay home for a day. And if you're not feeling better in 3 or 4 days, I want you to call me back. So I got my shot, I got my medicine, I went home, and sure enough, in a couple of days, I was feeling much better. So that little story, I'm sure all of us have been through situations like that. Well, that's the medical model. We just don't realize it. Here's what the medical model is. The medical model is symptoms lead to a diagnosis, which leads to treatment. I went in, the first thing they wanted to know was, what's your problem, right? They didn't say symptoms, but the nurse wanted to know, what are your symptoms? And I started sharing with her all of my medical symptoms. And she, as a nurse, and my doctor, as a doctor, are trained in listening for and understanding what symptoms mean. And that's why she asked me some questions. She was wanting to rule in and rule out certain things, right? So based on their training, they know what stuff looks like. They know what medical problems look like. And so my doctor, based on hearing my symptoms, it led him to a diagnosis. Upper respiratory infection was my diagnosis. And then not only that, now that he knew what was wrong with me, based on his training, he knows what to do to help people with that type of problem, the treatment. He gave me a steroid shot and some antibiotics, and he told me to rest for a day. And sure enough, it worked. My problem went away. So that is the medical model. Symptoms or people or problems, a cluster of problems, is organized into a diagnosis, and that diagnosis helps us to know not only what are people's problem, but what their problem is, but what we can do about it. Well, that's how the DSM-5 is organized. It is organized first on symptoms. Here are the symptoms of people that people often experience. And here's what we call it when people experience these symptoms. The bulk of this class is going to be focused on you learning the symptoms and the diagnosis. Post-traumatic stress disorder is a diagnosis. But my question to you is, what are the symptoms? Bipolar 1 disorder is a diagnosis. But what are the symptoms of that diagnosis? The symptoms come first. And so we're going to look in this class primarily at the symptoms and their corresponding diagnoses. Now, this class is not as much, and the DSM-5 is not as much interested in the treatment part, so don't let that frustrate you. The treatment part, you and I as professionals are responsible for, right? But for this class, especially the first two of those, the A, the D, the T, ADT, assessment, diagnosis, treatment. We're more interested in this class in the A and the D, assessment and diagnosis. All of that is the medical model. And the DSM is built upon the medical model. And so you're going to get a real good introduction. So the term symptoms, the term diagnosis, those are more medical terms because the medical model was really initially developed by our friends in the medical community. And what happened about 100 years ago was psychologists and therapists and counselors borrowed that idea and brought it over to mental health evaluation and assessment. So today, that's how we evaluate and how we assess people is we listen for their problems. And sometimes, not always, but sometimes that might lead us to like a diagnosis. Now, again, that's not always important. But sometimes for this class, we're going to act like it's kind of important because that's what sort of just the nature of this class. So we don't always diagnose people, but we're always evaluating people and we're always determining what sort of is the problem or the issue. It may not have a clinical name, but we're always assessing and diagnosing people at some level, right? And then we're providing help or treatment to them. And that's kind of the medical model, and that's really how the DSM basically is built. Last thing really quickly is this. I want to show you this handout. This is the third handout I've shown to you, and I want you to go find this little handout. One of the things I want you to be aware of, now that I've kind of sold you on and described to you how the DSM works, let me highlight for you this. There are a lot of benefits to using a tool like the DSM. There's a lot of benefits to the medical model. It gives us a common language to speak from and common terminology. It can provide information and education to the client. It's good for the client to know that their struggle has a name. Oftentimes, I'm not sure if you've ever been to the doctor or someone, the doctor maybe, and You told them your problem and your struggles, and have you ever had a doctor say, well, I don't know what's wrong with you, right? I mean, most of us, that's stressful. We want to know what's wrong with us. Well, sometimes in mental health conditions, it's helpful for people to be educated that, hey, this struggle that you have actually has a name. It's called depression. It's called whatever, fill in the blank. And that can be helpful for clients. The DSM is good because it gives us a standard point of reference in which to work from. It helps us to organize the complex range of people and their problems. It helps us in planning treatment. You can't provide treatment unless you know what's going on first. So good assessment leads to good treatment. So the DSM is a good assessment tool that helps us to thoroughly assess people and their mental health struggles. And if we do a good job there, it helps us then to effectively plan treatment. It also, too, is used to bill insurance companies. We don't talk a lot about that in this class, but the DSM is also beneficial because it helps us to bill insurance companies if we need to do that and provide what we call a third-party payer. There are some drawbacks, though. I want to highlight these because these are also important. The drawbacks mean that we just have, these are things we have to be careful about. We want to highlight the benefits. We want to be careful about the drawbacks. Okay, so for example, one of the biggest ones is that sometimes we can get stuff wrong. When it comes to diagnosing someone, we can and we do sometimes get stuff wrong. So the potential for misdiagnosis is always a potential problem anytime you're diagnosing somebody with something, whether it's a medical condition or mental health condition or whatever it may be. The other problem too is people can other diagnose or self-diagnose, if that makes sense. Other diagnosis where I diagnose my sister and I say, yeah, she's got this. Or I diagnose myself and I say, well, I watched a TV show the other night and I think I've got this problem. So we have to be careful about misdiagnosis or other or self-diagnosis. We always want to be careful about labeling, negatively, inappropriately labeling people. These diagnoses are kind of like labels because they are. And one of the potential dangers is we don't want to label people inappropriately. We also don't want clients to hide behind their labels, if that makes sense to you. When I worked in mental health counseling, let me give you an example of what I mean by that. When I worked in mental health counseling, occasionally, not always, but occasionally clients would hide behind their diagnosis by this. They would say, well, I can't go get a job. I have bipolar disorder. Well, the reason why I tore up my room last night, it's because I have this. Well, I can't do that. I have blank, right? And so they would shirk responsibility. Well, I can't live on my own. I can't go back to school. I have blank, fill in the blank. I have PTSD. And they would hide behind that diagnosis to basically not take responsibility for themselves. And that is never appropriate. But people will sometimes do that. If they have a mental health condition, they'll try to hide behind it if we're not careful. That's one of the potential drawbacks. We know that oftentimes the DSM-5, it's the symptom checklists are black and white. They kind of give us a clear picture, but they're also general. Those checklists are also general in nature. And so not every single person fits in neatly to every single checklist. There's variability among symptoms. There's variability among clients. And you'll hear me talk about that starting next week in Module 2 with schizophrenia. You'll hear me say schizophrenia has a set list of symptoms. How those symptoms look in individuals can vary from person to person. But there's a general set. It's a specific general set of symptoms that we look for. There's 5 of them. There's 5 general symptoms of schizophrenia. We'll talk about that next week. But how those symptoms look in person's lives, different people's lives, can vary from person to person to person to person. So it's not always really black and white. So, and that's a potential drawback or danger to the medical model. If we're not careful, we get over-focused on people's symptoms and we get over-focused on people's diagnosis instead of focusing on strengths and resources. I personally, if you've ever taken the counseling theories class with me, you know my philosophy. I am a personal believer that you and I as individuals possess both limitations and resources at all times. That's my personal theory. Do all of us have things we struggle with? Yes. Do we have things that we get right? Yes. Both of those are true. On any given day, you get a bunch of stuff right. You also get a bunch of stuff wrong. I do too. You know why? Because we're human. And so if we're not careful, with a diagnosing kind of a medical model symptom, because it's kind of focused on symptoms, which means problems. We get over focused on problems, and we don't realize that people have resources and strengths. At any given moment, we have both of those at the same time. And what we do in counseling is we help people to utilize their resources to overcome their weaknesses, right? That's a whole nother story for another day. And then again, the potential for cross-cultural limitations. The fact that the DSM symptom checklists are really general, and they cannot take into account all the different nationalities, ethnicities, cultures, all the different cultural differences. There's no way it can do that. So we have to be careful as clinicians that we aren't just slapping labels on people, and that we are ignoring people's unique cultural backgrounds, unique national backgrounds, their unique ethnic backgrounds, and how that influences who they are, how they look at the world, and how they behave. That's important for us. I mentioned to you earlier on the handout that that's one of the little small areas, it's one of the little sub areas that DSM gives us for every single diagnosis, which I'm glad it does. It gives us these culture-related diagnostic issues with every single disorder. That's given to us to help us to make sure that we aren't being culturally insensitive, and we're instead being culturally competent. The very last thing I want to give to you is this. It's what's called the mirror effect. Almost every single time I teach this class, the DSM-5, and we look at the DSM-5, this happens. People take their DSM-5. I'm going to take my DSM-5. Here it is. And here's what we do. Oftentimes we'll look in the DSM-5 and we'll say, well, that's me. I've got that. Well, I know, wait, I didn't know that's what that was called. I mean, whoa. We look in the DSM-5, we study, something, and we say, whoa, that's me. I have that. I struggle with that, right? And what happens if we're not careful is the DSM becomes a mirror, and we see ourselves in it. Well, here's the thing. You're going to see yourself in the DSM-5. I am too. Because all of us at different times in our lives have struggled with some of the symptoms listed in the DSM-5. There's no shame in that. But we want to be careful with the mirror effect. Several years ago, I taught this class in the summertime at night. I remember it to this day. And there were two ladies who sat at the back of the classroom. They were great students. I'd never had either one of them before. And we were taking I was teaching this class at night in the summertime. And the big running joke with them was we would talk about schizophrenia, for example. And while we're talking about schizophrenia, one of them would say under her breath, but loud enough for everybody to hear, ooh, I got that. And people would kind of laugh. And then we talked about schizoaffective disorder. And as I'm going through and reviewing the symptoms, one of the ladies would say, ooh, I got that. And then the next section, major depressive disorder. And one of them would say, ooh, I got that. Bipolar 1, ooh, I got that. Post-traumatic stress disorder, ooh, I got, with every, and it kind of became a running joke that each of them would say, ooh, I got that. And what was funny was about halfway through the semester, one of them caught me after class and she said, no, I think I really think I've got all these problems. And we laughed, but she was really concerned. Well, as we talked about it, she didn't. What she had was stress and problems and worries, and she had at times some things going on in her life that she was kind of sad and depressed about, and she had times in her life where she felt out of control, like the world was spinning out of, we all have been there. She had times, anyway, she had some things in her life she was kind of concerned about. In my talking to her, it didn't sound like she probably had really any mental health, diagnosis. She just had the typical emotional, behavioral kinds of struggles that all of us sometimes experience. But kind of the running joke that semester was, ooh, I got that, right? Well, that's kind of what the mirror effect is. So I want you just to be careful. Let's be careful as we go through that we are not self or other diagnosing. Self-diagnosing ourselves, other diagnosing somebody else, right? It's important to kind of, as best we can, it's hard to do in a class like this, but as best we can, I want you to try to stay as objective as you can. Try to be a student. And instead of trying to apply all of these different disorders and diagnoses to you or someone who you know, it's not easy to do, but I want to encourage you to do that. Okay, this is the end of our second little mini lecture for foundations. Go through, look at all the PowerPoints, look at all the handouts, do module number 1 homework, come back next week, couple more videos next week, and a bunch of other stuff in module 2 on schizophrenia. Have a good one. I will see you then.